Hi everybody and welcome back to our second journal club. As with every journal club, I'm personally excited, but I'm particularly pumped about this session because we have two outstanding speakers. Our session today will be about a subgroup of patients which requires our special attention, not children or pregnant women, but the immunocompromised. Our speakers today are Dr. Elaine Tennant and Dr. Camille Kotton. Dr. Tennant was educated among other institutions at the University of Notre Dame School of Medicine and the Liverpool School and the Australian Institute of Tropical Health and Medicine, and has been, until she recently relocated to Germany, an infectious diseases consultant at Prince Wales Hospital, Sydney, and acting co-director of the Communicable Diseases branch at New South Wales Health Australia. Dr. Camille Kotton attended the University of Chicago Graduate School of Medicine and trained at the University of Pennsylvania School of Medicine. She is the clinical director for transplant and immunocompromised host infectious disease at Massachusetts General Hospital and an associate professor at Harvard Medical School. Also a member of the CDC's Advisory Committee on Immunization Practices. Before we go through today's study cohorts, we'll actually go through the current recommendations by the CDC for the immunocompromised, and then towards the end we'll put the study into context. And with that, I'll hand over to Dr. Kotton.
It's really a pleasure to be here with everyone today. I will be talking about COVID-19 vaccines and sort of laying some framework for discussion of vaccines in immunocompromised patients. I know that this is an international call. My focus will be on a summary of the U.S. Center for Disease Control CDC guidelines, but obviously that changes in different locations. So what is the definition of immunocompromised patients? And you can see here that it's people who are actively undergoing treatment for tumors and hematologic malignancies, those who have had solid organ transplants and taking immunosuppression, people who've had CAR T-cell therapy or stem cell transplants, also moderate or severe primary immunodeficiency like DeGeorge syndrome or Wiskott-Aldrich syndrome, people who've had advanced or untreated HIV infection, in other words, low CD4 count, et cetera. And then perhaps one of the bigger categories is anyone who's on treatment with high-dose corticosteroids, at least 20 milligrams of prednisone per day when administered for at least 2 weeks, alkylating agents, antimetabolites, transplant-related immunosuppression, TNF-alpha drugs, other biologic agents. And then important to think about their immune competence in patients, including disease severity, duration, clinical stability, complications, comorbidities, along with their immune suppressing treatments. So this does account for approximately 3% of the US population, and it is one of the populations that has suffered the most during the COVID-19 pandemic from severe illness. So just to highlight, what are the current recommendations for non-immunocompromised? You can see here that for those aged 12 and older, it was recommended that there be a 2-dose mRNA scheme and now followed by a booster dose at least 5 months after the second dose. Okay, so I call that the 2+1. 2 initially, followed by 1 5 months later. If it were a Janssen J&J vaccine as the first dose, there should be a booster dose at least 2 months after the first dose. And in December, we said that preferentially that should be an mRNA vaccine. Okay, so that's the playing field for non-immunocompromised. And then for immunocompromised, I call this the 3+1. So basically it's 3 full doses of the primary vaccines followed by a booster dose at least 3 months after the third dose. So this is really the 3+1, as you can see here. Janssen is a dose of Janssen vaccine followed by another vaccine at least 4 weeks later, and then a booster dose at least 2 months after that additional dose. A little bit confusing, but it's either 3+1 or the 2+1. And I would like to highlight that at the bottom, there's this great website that if you bookmark this, you will have all the answers to COVID vaccines that you could possibly want. It's very dense. There are great things in the appendix. I refer to this many times a day. So what about, we get a lot of questions about, can we make vaccines recommendations based on antibody testing? And that is not recommended at this time because we don't have appropriate thresholds for protection. It also doesn't measure the cellular immune response. And I wanted to highlight for this audience that there are additional considerations that came out February 11th. But so on a case-by-case basis, we can make recommendations for moderately or severely immunocompromised patients to give an additional dose of vaccine when needed, when the benefits of vaccination are deemed to outweigh the potential and unknown risk for the recipients. This doesn't mean that we should, just randomly make things up, but when you think that somebody really likely did not have a good immune response to their initial series or any of their doses of vaccine, maybe they were getting steroids for, COPD flare or any number of things, you are now allowed to have flexibility to repeat those doses of vaccine. And then another part of this is also think about treatment guidelines for the use of monoclonal antibodies, as well as pre-exposure prophylaxis for moderately or severely immunocompromised people who may not mount an immune response to COVID-19 vaccine. And then just to highlight from the NIH guidelines that who should get pre-exposure prophylaxis, there are a lot of questions about things like Evusheld. Evusheld, which is this combination monoclonal antibody, is not authorized for use in unvaccinated people. So it is really meant as, somebody's been fully vaccinated with all the doses I described, and then an additional dose of Evusheld on top. I kind of call it a belt and suspenders. You have both vaccines, but where in people in whom the vaccines may not engender a robust immune response, Evusheld provides monoclonal antibody protection, a different way of protecting people from COVID-19. Who needs pre-exposure prophylaxis? There's a well-defined list from NIH, which is quite similar to the list I already presented. And that's just, all of this is really food for thought for what Elaine is now going to present in this paper. But I wanted you to all know sort of the ground rules of what the current recommendations are. Elaine, over to you.
So thank you very much, Camille, for that great summary. And Ben, thanks very much for the opportunity to present this incredibly interesting study, which I think, for hospitalists is very close to our hearts, because we've all seen the impact of, periods of strict lockdowns and social distancing ending. There's jubilation generally as we return to a normal, more normal life. But for our patients that are immunocompromised, this has really created significant anxiety as the world has become what feels like a less safe place for them. All right, so similarly to America, in Australia, we think that there are about 3% of patients that are considered to be immunocompromised. And so this represents significant numbers of patients that are affected. Based on a systematic review process, the CDC classifies several medical conditions as presenting higher risk for severe outcomes from COVID-19. And these conditions are covered in the paper that I'm going to talk about. Also, previous studies have suggested that vaccines elicit poorer responses in immunocompromised people, and as has been stated, receipt of an additional dose as part of the primary vaccination course may enhance this response and is part of vaccine policies in several countries. However, this is a very heterogeneous group when we use the word immunocompromised. So when we make clinical guidelines and policies, is it reasonable to lump all of these people together, or do we need more of a nuanced and individualized approach to quantify the degree of risk for individuals? So the goals of this study were to assess the factors that elicit poor antibody responses amongst immunocompromised people, and to measure neutralization titers after COVID-19 vaccination in individuals with a range of immunocompromising conditions compared to non-immunocompromised patients. So this was a prospective observational study, which was kind of really run electronically and based on the EMR records. So it involved 1,271 adults who had completed their vaccine series and had not been infected with COVID as far as could be ascertained. So this meant that there were just over 1,000 immunocompromised patients, and for the control group, they used hospital workers who had no known immunocompromising conditions. The study took place between mid-April and mid-July last year. The setting was in Pennsylvania, as discussed, and recruitment was mainly carried out via online word of mouth, hospital emails, hospital advertising, and discussions with individual clinicians. Patients entered their own conditions and medications, and then this information was verified by the study team on chart review, and the data was managed using REDCap for collection and management. So the primary outcome was the proportion of immunocompromised individuals versus healthcare workers who had a reactive IgG for SARS-CoV-2 spike receptor binding domain. And the secondary outcome looked at comparing antibody levels with pseudovirus neutralization titers. So as mentioned, there were 1,099 immunocompromised patients, and these fell into 5 different groups. So 41% were solid organ transplant recipients, 14% were hematological malignancy patients. There were 23% of the group who had autoimmune or chronic inflammatory conditions, 12% had solid cancers, and 8.6% had HIV infection. The controls were non-immunocompromised healthcare workers. If a person had been infected with COVID, they were excluded. This was based on self-report and verified by a review of PCR results from the EMR, noting that this was performed within a district, so there was obviously not visibility of tests that had been performed at other hospitals or in other areas. And so in terms of the inclusion criteria, adults had to have completed a vaccination course, and at this time the standard of care for all patients, including immunocompromised patients, was a course of 2 doses of an mRNA vaccine and 2 doses of AstraZeneca or 1 dose of Johnson & Johnson. And that's obviously changed since then, which affects how we kind of interpret the study. So in terms of the antibody assays, so all patients and healthcare workers had IgG measured. And then amongst a subset of the patients, they also did, I guess, a validation study to test the IgG levels on an alternative platform. So that was amongst 245 subjects. And then they performed pseudovirus neutralization assays on 100 subjects, so 50 healthcare workers and 50 immunocompromised patients. And I'll talk about that in a little bit more detail. So in terms of the antibody assays, as I said, it was an IgG against the S protein RBD, and the signal to cutoff ratios were interpreted either as seropositive, so anybody that was that had a serum to cutoff ratio of greater than 1 was considered as reactive or seropositive. Anybody that was equivocal, so less than 1, even in that mid-range between 0.8 and 1, or who was considered negative at less than 0.8, they were classified as seronegative. So it was a binary outcome. And then, as I mentioned, they used a second platform, the BioRad assay, on a subset of patients to see whether there was concordance between the 2 platforms. So in terms of pseudovirus neutralization titers, so they were performed to determine whether the IgG antibody levels correlated with actual virus neutralization in vitro. How was this done? So HEK293 cells are an immortalized cell line commonly used in cell biology research. And as we know, SARS-CoV-2 infects cells by its spike protein attaching to epithelial cells through the surface receptor ACE. And so they used human ACE HEK293 T cells that have a human ACE2 gene integrated into the cell chromosomes to form a clonal cell line that stably expresses ACE2. And then they used a pseudovirus to infect these cells. So pseudoviruses are non-replicating viruses that permit research in a lower biosecurity level lab. and they're commonly used in vaccine studies. So they use serially diluted sera incubated in the presence of the pseudovirus and used it to infect the HEK2 cells. And then they measured the proportion of cells infected by luminescence at 48 hours. Results were reported as the highest serum dilution that neutralizes more than 50% of the pseudovirus. So, and that's expressed as NT50. So high NT50 would indicate high neutralizing antibody activity. As I said, there were 100 subjects in that group. So what about the baseline characteristics? So I apologize for the small writing, but there's quite a lot of information here condensed onto a small table. I've highlighted in red the areas that are of particular significance. So the groups were different. You're looking at comorbid immunocompromised patients against healthy healthcare workers. So there were significant differences in terms of age. There was a preponderance of females amongst the healthcare workers group. There was, across the board, with the exception of obesity, there were significant differences in comorbidities, which are listed here between the immunocompromised and the control group. And it was a predominantly white population, so that might influence generalizability for interpretation. The other point to bring out was that the number of days from the second vaccine was recorded, and amongst healthcare workers there was a longer duration of time, and that obviously reflected the earlier rollout of the COVID vaccine amongst healthcare workers compared with the general population. In terms of vaccines, the vast majority of people had an mRNA vaccine, and very few had an adenovirus vector vaccine. Of those that had an mRNA vaccine, there was a pretty close to 50-50 split between Pfizer and Moderna. I'll expand a bit more later about the level of the nature of immunocompromise of patients in the group. So, results. So seropositivity and antibody levels. So first of all, concordance between the platforms. So generally there was good agreement between the platforms as indicated by Spearman R analysis, which showed that the results were highly correlated with a p-value of less than 0.001. Although 13% of results overall were discordant. And particularly for HIV patients, there seemed to be a fairly high rate of discordant results. And I think that's one thing that indicates or supports the recommendation that using serology can't necessarily be relied upon. So what about seropositivity and antibody levels? So patients in the immunocompromised group had significantly lower antibody responses and rates of positivity, and the extent depended on the underlying immunocompromising condition. The median antibody levels were markedly lower among those with solid organ transplants and hematological malignancies compared with other groups. Healthcare workers had a rate of 92.4% seropositivity, compared to 55.1% amongst the immunocompromised group as a whole. And amongst solid organ transplant recipients, the seropositivity rate dropped to 30.7%, so it was pretty low. The authors performed a multivariable analysis looking at factors that were associated with a negative antibody response by underlying condition. And I've summarized these on the slides in the table. There were variables that they examined for all of the groups, and then obviously there were factors that were specific to each underlying immunocompromising condition that they analyzed separately within the group. So for variables that they looked at across all of the groups, they looked at age groups, and the way that they classified the age groups was 19 to 44, 45 to 60, and 60 plus. They looked at gender, they looked at race, and they looked at type of vaccine received. And then also median days from vaccination at the time of the blood draw. So for healthcare workers, out of all of those factors, time from vaccination was significantly associated as a predictor for lower odds of seropositivity. And the reduction in probability of having a positive antibody test reduced each month post-vaccination. So at 30 days post-vaccination, it was 99.8%, and by 150 days, it had dropped to 91.8%. So we're still fairly high. The pattern of antibody dropping with time was seen across most of the groups. For solid organ transplants, factors significantly associated with lower odds of seropositivity included a greater age, non-white race, and vaccination with Pfizer as opposed to Moderna. Vaccination, and then in terms of specific factors, vaccination within 1 year of the transplant, probably associated with heavy immunosuppression, came out as a predictor. The number of immunosuppressive medications was more likely to be associated with low seropositivity. And there was a difference between the different types of organ transplants. So if you had a liver transplant, then your odds of having a poor vaccine response was less than, for instance, if you had a kidney transplant. There were only 9 patients who'd had a recent episode of rejection, so pretty small numbers, but there was no association found between them and having a poor vaccine response. There were 2 other conditions for which it was found that there was an increased risk of seronegativity following vaccination with Pfizer as opposed to Moderna, and those were autoimmune conditions and solid tumours, and I'll discuss that in a bit more detail. The other factor that came out amongst several of the groups was that anti-CD20 monoclonal antibody therapy was associated with lower odds of seropositivity on multivariable analysis. For HIV patients, the group was fairly well, so 86.6% of patients had a CD4 count of greater than 200, and most of them were virally suppressed as well. And there were no general predictors amongst that particular group of having a reduced vaccine response. However, for those that did have a CD4 count less than 200, there was a significant risk of poor vaccine response. I've just written the hematological conditions, so these are fairly small numbers. There wasn't any evidence that underlying hematological condition affected seropositivity. 9 of the patients had undergone a stem cell transplant, whereas 3 had undergone CAR T cell therapy, and the seropositivity rates for those particular patients was 66.7% and 33.3% respectively. Amongst those patients with autoimmune conditions, that was around 200 patients, the only medication that significantly impacted vaccine response was anti-CD20 agents, and I've listed on the slides the number of patients that were taking a various array of other medications. What about solid organ transplant patients? So some previous studies have demonstrated that antimetabolites such as mycophenolate and azathioprine are associated with poor humoral responses to COVID-19 vaccinations. However, in this study, it was really the addition of further medications, regardless of whether they were antimetabolites or other immunosuppressants, that was associated with lower rates of seropositivity. And just going back to the list of autoimmune conditions, the anti-metabolites in that group were also not found to be a predictor of poor vaccine responses. Similarly for cancer therapies, so I've listed hematological malignancies and solid tumours here pulled out from the paper. There were no specific chemotherapeutic agents that came out as being associated with poor vaccine responses apart from anti-CD20 agents. So these are a worry, and I guess the mechanism of action makes this unsurprising. So 4.6% of all of the immunocompromised patients had received anti-CD20 therapy in the 12 months prior to being vaccinated. And there was clearly a significant effect on seropositivity for all patients. So only 17.7% were seropositive compared with 57% of patients that were immunocompromised that hadn't received those agents. And so after adjusting for age, time from vaccination and type of vaccine, the authors found that there was an 84% reduction in attainment of seropositivity in vaccination in this group. So as well as the binary outcome that has just been described of seropositivity or seronegativity, the authors did a further analysis looking at the continuous variable of actual antibody levels as measured by the serum to cutoff level. So amongst all immunocompromised participants, there were significantly lower levels compared with the healthcare worker group. And I've just pulled out figure 1b from the paper on the slides to illustrate that. And the previous slide was looking at all patients. They also performed the same analysis amongst patients that were classified as seropositive. And they found that those particularly with solid organ transplant, who were solid organ transplant recipients, had a significantly lower level of antibodies than those amongst the healthcare worker control group. So what about vaccine type? I mentioned before that for the binary variable of seronegative or seropositive, there seemed to be a worse response with Pfizer as opposed to Moderna. And this was quite marked. So looking at antibody levels as a continuous variable by vaccine type, the same kind of pattern emerged. So antibodies associated with mRNA 1273 or Moderna were significantly higher than for BNT 162b2 or Pfizer, or an adenovirus vector vaccine. And that was after adjusting for time since vaccination age and underlying condition. So the mean antibody levels for Moderna were 10.4, 5.25 for Pfizer, and 1.82 for adenovirus vector vaccines, noting that in the latter group, there were very few patients. So the next slide shows the correlation between antibody levels and serum to cutoff ratio and pseudovirus neutralization assay titers. And so overall, amongst the group that were tested, so this is 50 patients, there was close correlation between the IgG antibody levels and the neutralization titers. Neutralization titers were lower in the immunocompromised group than the healthcare workers. So a median of 52.2 versus 181.5 respectively, and that was statistically significant. However, when the neutralization titer results were separated out into subgroups per antibody level, it was evident that for subjects with antibody levels between 1 and 10, there was a significant reduction in neutralization titers amongst the immunocompromised group. So a median of 55.5 versus 93.9, which was statistically significant, despite there being no significant difference in antibody levels between the groups. So if you check the antibody levels, you could be falsely reassured that your patient is protected, but when you looked at the actual neutralization assay titers, they were low. And so I think that report supports the recommendation, again, that serology shouldn't be relied on for assessment of vaccine response in immunocompromised patients. For patients that were seropositive and had an antibody level of greater than 10, that discrepancy with the neutralization assay titers wasn't seen. And you can see that in the red boxes. So what about breakthrough infection? So this wasn't a clinical study and it wasn't looking at clinical outcomes, but they did report that within the median follow-up time of 67 days, there were 2 patients within the group who developed COVID infection. Both of them were seronegative. One had advanced HIV and was hospitalized with COVID pneumonia, and one was a kidney transplant recipient and sadly passed away from COVID-19 respiratory failure. They looked at the number of patients who had undergone PCR testing within that area, their hospital EMR facilities within that period, and they were all negative. So they weren't aware of any other COVID infections within the group. So in terms of summary of the main findings, this was a prospective observational EMR embedded study of just over 12,000 adults who had been vaccinated for COVID-19, had no history of prior infection, and was looking at immunocompromised patients compared to healthy controls. In terms of the major findings, there was clearly reduced seropositivity amongst immunocompromised patients compared to non-immunocompromised healthcare workers, noting that this was a 2-dose primary schedule, with the exception of Johnson & Johnson. The rates of seropositivity varied per group and were lowest amongst solid organ transplant patients. Compared to healthcare workers, which were 92.4% positive, seropositivity amongst the SOT recipients was only 30%, followed by patients with hematological malignancies at 50%, solid tumours, autoimmune conditions and HIV all lying in the 70 to 80% range. It was clear from the study that anti-CD20 and heavier immunosuppressive regimens in terms of number of drugs rather than type was associated with lower rates of seropositivity, and the antibody levels declined with time. The study also found that vaccination with Moderna was associated with higher antibody levels compared to Pfizer or adenovirus vector vaccines, and virus neutralization titers corresponded generally with antibody levels, but amongst those with lower positive antibody levels, there was not good virus neutralization, which was interesting. The study had several limitations. So there was potentially some selection bias in terms of online recruitment, so more likely to be recruiting people that were highly engaged in care. There were differences between the studied and the control groups, which have already been discussed. The healthcare worker group were longer from vaccination, although you might have expected then that the difference observed was in the vaccine response would have been more pronounced or underestimated. There were low numbers of stem cell transplant patients, and if you work in a transplant center, then you really want to know that information. And then also low numbers of non-white patients, which might limit generalizability. The study assessed obviously humoral and not cellular immunity. It didn't look at clinical outcomes, so how do we translate this? We're not entirely sure whether patients had been infected with COVID previously. The processes to ascertain that information were not very robust. Finally, the neutralization titers were derived from a non-Delta, non-Omicron strain of COVID. So it's hard to know whether the results would be applicable to these variants, which are circulating more commonly at the moment. So I'm going to hand over to Camille for some discussion about this paper and putting it in context with the rest of the literature. Thank you.
Elaine, thank you so much. That was magnificent. It's a huge paper, a lot of data, but you did a beautiful job with that. So as you nicely highlighted, this work was done before August 2021 when we made that recommendation for the 3rd additional dose as part of the primary series. This is the type of work that helped guide our thinking at that time when we made that recommendation. It's actually been an amazing journey on the CDC Advisory Committee on Immunization Practice because we've had to make vaccine recommendations without a lot of robust study data because we couldn't really wait for things to be done when we just had to save lives in the setting of an international pandemic. So it is a pretty heterogeneous group. I think they did a nice job with what they had. It does highlight the issues that we've had in the United States where we don't have a large, robust ability to collect good public health data. That's been highlighted where, Israel has done an amazing job showing the data, all the information we need, their ability to accumulate information rapidly and make rapid recommendations has been phenomenal. And we have not had that in the United States. So this is the state of Pennsylvania, which is great, but we certainly could do better. I saw that Ashish Jha will be working at the White House now, and he's a big public health person, so hopefully things will improve. They did just look at antibody response, not cellular response. And as you've highlighted, there are some issues when we just look at the antibody response. We have seen a disconnect in the organ transplant population where some people have a more robust response to by antibody. Some are more robust by cellular, and they don't always correlate. There are a lot of common themes that we've seen in other work where Moderna does look to be a little superior to Pfizer. One thing that we don't know is really if that holds true when we have the booster dose Moderna, which is 50 micrograms, not 100 micrograms. So we don't really know that full impact. I say it's a coin toss as far as which one you get for a booster, either full dose Pfizer or half dose Moderna. We've also seen that liver transplant patients seem to be better protected by vaccination in other studies. And then we've definitely all seen the impact of the anti-CD20 therapies in this population, and they've had these prolonged courses, and it's been pretty devastating, which is definitely something that you highlighted in the paper. But I think, my bottom line is it's a magnificent tour de force to have all of this work done. Moving forward, I think that we need to stay up to date on our recommendations for additional doses of vaccine, boosters, monoclonal antibodies. We need to continue to gather data and best help protect this vulnerable population, estimated to be 3% of the US population, and significant in other countries as well, so that we can help prevent them from getting COVID-19.
All right, I think we'll end here. Drs. Tennant and Kotton, thank you both so much. Please send us feedback via tweets, get on our mailing list, and see you next time. Thank you.